Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for this webinar. Today we are back with our series Med Mocha Meetup Season 1 and Session 8. So it's my privilege to introduce the organizer of this webinar, Dr. Ritu Santwani ma'am. Ma'am has done MBBS, MD, FICOG, FIOG, AMRCOG, consultant obstetrician and gynecologist IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, infertility specialist. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am, and I hand over the session to you.
Yeah, thank you, Sahiti, and thank you, Shield Pharma, and thank you, my dear friends who have joined all across the geography. Now, friends will start joining within few moments. So, a warm welcome to each and everyone. Friends, as you all are aware, this series is going on from last 3 years, and I can say, by the help of the friends and by the help of the stalwarts, and of course, the blessings of my Mata Rani, the program is still rocking. Though now there's a time of the physical CMEs, still our webinar is going good. So because the only motto for these webinars is purely the academics and sharing of every week I invite some of the stalwarts from our fraternity to share their immense knowledge with us. So without any further delay, I would like to invite the chief guest of the program, our very dear Dr. Tarini Taneja Madam. A warm welcome to you. Sahiti, may I request you please introduce the madam?
Yes, ma'am. So it's my privilege to introduce the chief guest of this webinar, Dr. Tarini Taneja ma'am. Ma'am is the chairperson of ISA Delhi, international member FIGO Working Group of Breast Disease, executive member of DMA, vice chairperson of DMA Women's Wing, RCOG associate member, editor past UP and Delhi ISA, board member of Journal of Ops and Gyn Research and Practice, president of NGO Manzil-e-Rahat for Women Empowerment. Ma'am has several publications to her credit. Ma'am has received numerous awards, including Bharat Gaurav, Gold Icon Award, Inspiring Woman Award, Lifetime Achievement Award.
It's okay, Santi. Okay,
Yes.
thank you
Maybe
so
one more
much
time,
for
please.
your detailed introduction. I'm really
Yes, ma'am.
happy.
Yeah.
First of all, I'm really feeling privileged to be here, privileged and blessed to
Ma'am,
this international repute platform. And
ma'am,
also
warm
happy
welcome.
I'm with
Yes.
my two thank you, dear. Two dear friends, Dr. Kanchan, Dr. Ritu, both of them are very, very close to my heart. So it's really happy. Dr. Ritu is really so much of interested in spreading the education. It's really take time. It's take so much, energy and efforts to put. And but she's doing for last, I think, so many years. I don't remember. And everywhere, wherever we go, people say, "Oh, Dr. Ritu, जो जिसका के प्लेटफॉर्म चलता है, academic webinar चलते हैं जिनके regular." So she is so popular, and today I'm really happy that the speaker is a very, very academician, Dr. Kanchan Sharma. She will take the very, important topic that is a very rare disease, not even talked, and she's talking, I think, first time, that is the pericardiomyopathy. That's a very rare but very, very important, because nobody very aware about this topic. And many women, even in the young women, they are getting the heart attacks. So one of the important causes is the cardiomyopathy, because in the prolonged labor, whenever if the patient is not being supported, is a very big marasmic, whatever the nutrition is not good, then that time the heart expand if it is not supported by the medicine, and by the later on by her good lifestyle. So they are really more risk for the cardiac failure, heart failure. Or the problem is also that we are really feel the set for the women. But also if she is under the treatment of Sabda, like clinician, then the clinician is really in the hot water. So anyway, it's too much. I will want to listen from Dr. Kanchan on this subject. So over to Dr. Kanchan.
And we have to introduce for the guest of honor also. First of all, thank you.
Yeah.
1 minute, Sahiti, please. Huh. So, first of all, thanks a lot, Tarni madam, for giving your blessings for this academic event. Yes, for the Tarni madam, I can say one line: a friend in need is really indeed. So, madam is like that. Ki whenever you want her help, even though howsoever she is busy, आई डोंट नो हम लोग का मैडम के साथ कैसे ऐसा इतना अच्छा ट्यूनिंग है कि हमें जब भी कुछ चाहिए होता है या कुछ भी प्रॉब्लम है तो वी कैन call madam or sir at any time and they are always ready to help. So ma'am, once again, really we are honored to have you with us. And
Thank you,
meanwhile,
dear. Thank you, dear. It's always my privilege to be with you, Dr. Kanchan Sharma, to all my friends. I'm always
thank,
there.
It's a
So nothing to
thank
worry.
you.
I feel I should maintain my dignity of seniority. I always feel so. I do.
Thank you so
Thank you, madam. Thank you. Thank you so much. Meanwhile, I want to welcome the Professor Ibrahim, a very big name from the KDO, has joined. A warm welcome, sir. I met sir in the Dubai conference. Till then, sir is always exchanging his academic thoughts with me. Sir, warm welcome. Dr. Mona has also joined from the KDO. Yeah, Geeta Khanna madam has joined. Geeta Khanna madam always joins every week whenever I do the webinar, whether afternoon or night.
Yeah.
Madam always joins. Warm welcome, madam. Good to see my dear friends, Dr. Dhananjay. Uh, Beena madam has also joined. Rest have joined from the YouTube. I will take their names also. So now I would like to invite the Kiran Sinha madam, our uh, guest of honor for the today. Sahiti, please do the honor
Yes,
of
ma'am.
introducing the ma'am.
Yeah, it's my privilege to introduce the guest of honor, Dr. Kiran Sinha, ma'am. Ma'am is a senior consultant, obstetrician and gynecologist, Kanpur, retired from PMHS as Joint Director, Kanpur Mandal, after 35 years of services. Ma'am has served in many district women hospitals of UP as gynecologist, trained and conducted many government-related programs like SIF, PSA, family welfare programs, AIDS, medico-legal trainings, etc. Presently, ma'am is a senior secretary of KOGS and also secretary of ISOPAP Kanpur chapter. Ma'am has chaired many sessions in UPCOG, AICOG, and many online and offline conferences. I welcome you, ma'am, and I request you to give the welcome address.
Yes. Warm welcome, Kiran madam.
Yes.
And thank you for accepting the invitation. Madam is also a very great accommodation. Always, whenever you attend any webinar, you always find the Kiran madam. If she is having a time, she definitely and she always give the positively involved in the interactions also. So, madam, I'm really grateful to you that you have taken out your time and accepted my invitation. Madam, over to you for gracing the blessings.
Thank you so much, Dr. Ritu, for inviting me. I I really love learning every time, and most of the times I love this webinars more as compared to physical meeting, because you don't waste your time, you don't waste your patient's time and everything, and you don't waste your energy also in going from here and there. And moreover, in the webinar, you meet so many people, and you, if you want to learn something, the webinars, they are the best one. And because you make so many friends, कि आपका कहीं भी काम कुछ हो जाएगा, कोई पेशेंट आपका अगर पूना में है, रितु संतवानी के पास मुझे भेजना देनी, मैडम बता दो यहाँ पे हम हैं, क्योंकि आजकल के सबके बच्चे बाहर हैं। अभी डिलीवरी करानी थी एक आध यहाँ पे डॉक्टर लड़की जिनके बच्चे बेंगलोर में है, तो आई टू सेंड देम टू डॉक्टर शीला माने एंड एवरीथिंग. So I really love it more than physical meeting. And thank you so much, Ritu. Ritu, I just want to say कि जितने भी topics होते हैं, they are very crisp and short, and I am really proud of my colleague Dr. Kanchan. She is a very good orator. She is always, आप किसी भी topic पे कह दो, she is always ready to speak. And I think now she has become a national figure from Kanpur. My blessings to her always. And thank you so much, Ritu, for inviting me. As Dr. Tarini has already introduced about cardiomyopathy, this is most of the time is missed during ANC period, though it is not in the AICOG guideline to get the ECG and the echo of every of the patient of ANC. But since after retirement, I started doing my private practice most of the times, especially after COVID. once I always get ECG at least, and the if possible echo also of the patient, because you are always safe that you have investigated the patient. You see, you never know कि the patient is suffering from cardiomyopathy. अक्सर कहती है मेरी सांस फूल रही, मुझे थकावट, घर वाले कहते हैं डॉक्टर साहब ये तो काम चोर है ये वो, लेकिन we should not miss that thing. तो आफ्टर कोविड आई हैव लर्नड अ लेसन फ्रॉम दिस थिंग कि मतलब दो पेशेंट होते हैं, एक हार्डली मेरे ख्याल से 2000 में हो जाता है ईसीजी को दोनों, तो आई मोस्ट ऑफ द टाइम गेट इट डन. तो and so that at least we have got the things with us ki this patient is safe. Suppose something wrong happens, then you are always put into trouble. And the patient, they never hesitate in doing investigations done. They always hesitate in giving fees to me and to Dr. Geeta Khanna and to you and to Dr. Tarini, but not to the investigations. With this, I just want to learn more and more about cardiomyopathy. So I hand over mic to you again.
Thank you, Kiran madam. Now let's invite for the speaker of the day, my very dearest Kanchanji. Kanchanji, I think doesn't need any introduction. A very popular, and she has done the enormous work, and really she's always ready for the knowledge sharing. So I know her schedule is very busy. She's also have a lot of travels also, but she accepted the invitation. Thank you, Kanchanji. Yeah, Saiti, please do the honor.
Yes, ma'am.
Hmm.
So it's my pleasure to introduce Dr. Kanchan Sharma, ma'am. Ma'am is the chairperson of NCD Committee Foxy, and ma'am is the director and chief consultant Akash IPF Center Kanpur, secretary of KOGS from 2021 to 23, president of IHRF Kanpur, ART specialist, laparoscopist, and colposcopist. Ma'am has more than 33 years of experience, and ma'am has received numerous awards, including Foxy Achiever Award, Pratigya Social Impact Award, Empowered Women Award, Nari Ratan Samman and the Corona Warrior Award, Nari Suraksha and Nari Samman Award from Police Commissionerate, Lifetime Achievement Award from KOGS Kanpur. And the ma'am has conducted many academic events, such as organizer of many national and international conferences, organizer and chairperson at ultrasound workshop of UPCOG, UP gynecologist in 2015, quiz master in WWF conference in which respected President of India was present, and speaker in the National Conference of Hyderabad and the AMOX 2022 in Aurangabad. And ma'am is the life membership. Ma'am has life membership in Foxy, IAGE, ISAR, IFS, IMA, IAMS, ISOPAB, NARCHI. And also, ma'am is the Vice President, Joint Secretary, and Cultural Secretary, Treasurer of Cox. So, I welcome you, ma'am.
Thank you,
Thank
Sahiti.
you, Sahiti, for the nice words. First
A
of
very
all,
warm welcome, Kanchanji. A very warm welcome. Yes, we
Thank
all are
you.
eagerly waiting to hear you. And once again, thank you for accepting the invitation.
I am sharing the screen. Thank you. Meanwhile, I want to thank my dear friend from GSVM Medical College, Dr. Ritu. Really, you are doing great work. You are organizing such a wonderful webinars. Everyone is liking it. My thanks and regards to Dr. Tarani Madam. You are the chief guest of the day. Really, you are a real brand in a real sense. Dr. Kiran Sinha Madam, you are the guest of honor, and so many thanks for your nice words and blessings. So coming on the topic, I think my slides are visible.
Yes, visible.
And they are full screen and I am audible.
Yes.
My thanks and regards to all the great audience and the speaker and the faculty from inside the India and outside the India. My topic today is the peripartum cardiomyopathy. As already has been discussed, slides are
yes moving.
Yeah, that I'll start this with a case scenario. This is a case scenario. Mrs. X, 38 years. She's a para 3 with history of hypertension and obesity presenting for the shortness of the breath, cough and the lower extremity edema. These type of patients do come to us usually during the time of the pregnancy. She had a vaginal delivery of twins at 36 weeks of gestation, this particular patient. And her pregnancy was complicated by the preeclampsia. Her vitals at the time of the presentation, when she presented to me, her vitals were blood pressure 132/92 and heart rate was 110 per minute. Oxygen saturation was 99% on 2 liters of oxygen. On examination, her JVP was raised, bilateral basal cryptations were present, and 2+ pitting edema up to knee bilaterally were there. Lab diagnosis BNP 1498. Normal value is 125 picogram per ml. HS drop 824 nanogram per liter, while the normal values for high sensitivity cardiolipin is below 14 nanogram per liter. CR1 hemoglobin 10, CR is creatinine. Chest X-ray enlarged cardiac silhouette was seen in the chest X-ray, and there was pleural effusion in both the lung fields. ECG showed sinus tachycardia. So coming on, what is the diagnosis and what are the differentials? This is very important. These type of the patients do come to us in usually in last month of the pregnancy or post delivery in the 5 months. Then we have to suspect what are the differential diagnoses. Seeing this type of the patient, many of the questions do come in our minds. What are the normal cardiovascular changes in pregnancy that we should all know? How they vary? What is the definition of PPCM, peripartum cardiomyopathy? What is its epidemiology? What is its etiology? What is its diagnosis? How does these type of cases present to us? How do we manage them? What is their outcome and what is its conclusion? So coming on the physiological changes in the pregnancy, this is very important. First, we should know the normal physiological changes because many times these may resemble to cardiac disease. Because the heart rate in the first trimester that increases by 5 to 10%, while in the second trimester it increases by 10 to 15%, and in the third trimester, as shown in this table, increases by 15 to 20%, and labor and delivery increases by 20 to 30%, and during postpartum period they come down to normal value. What happens to the stroke volume? We should know that in the first trimester it increases by 5 to 30%, in the second by 30 to 40, and in the same way this is stroke volume that reduces during the third trimester by 20 to 30%. And during labor and delivery again increases by 300 to 500 ml with each contraction, and in postpartum period it again come back to normal and reduces. What about the cardiac output? It increases in the first trimester by 5 to 30%, second trimester it increases by 30 to 40%, and more than 40% in the third trimester, and more than the 50% during the time of labor and delivery. And the postpartum period, what happens to it? Initially there is increase and then there is a fall. What about the systolic blood pressure? Either it remains same or reduces in the first trimester. In the second trimester, again there is a reduction. And the third trimester, either the same or increases. And during labor time, it again increases. And what happens postpartum? It comes to baseline. The same about the diastolic blood pressure. Same changes that happens. And what about the systemic vascular resistance? It reduces by 10 to 30% in the first trimester and reduces by 30 to 40% in the second trimester, and the third trimester it reduces by 30 to 40%. But during the labor and delivery, it increases and again come back to normal in the postpartum period. So after seeing this, we have to differentiate between the normal cardiac finding and the abnormal cardiac finding. I have given a table to differentiate between both of them. So these are the normal findings in the pregnancy, which may resemble with some cardiac finding. These are the raised GVP with a prominent pulsation, may be a normal finding. Brisk and diffuse apical impulse may be shifted lateral and upwards. loud S1 and S2 with the widely split. Occasional S3 may be present, sometimes normally. Aorto and the pulmonary flow murmur may be present normally. Memory, shuffle, and edema. While what are the abnormal findings? This is a progressive dyspnea which is increasing. There is a chest pain. There may be hemoptysis, maybe syncope, maybe cyanosis, or maybe clubbing. There may be systolic murmur grade 3 or above. Persistent neck vein distension may be there. There may be diastolic murmur. There may be persistent arrhythmia. There may be persistent split S2. So, coming on the definition of peripartum cardiomyopathy, this is very important. There may be all four of the following. What is this? A patient who is normal initially may have these features even. First of all, there may be heart failure within last month of the pregnancy or the 5-month postpartum. There is an absence of prior heart disease. This is very important. The patient who is always coming to you with the normal cardiac findings may develop these features in the last month of pregnancy and the 5-month of postpartum. So you have to always be prepared and keep these findings in your mind. There may be no detrimental determinable cause. Strict echocardiographic indication of the left ventricular dysfunction are there. There may be reduction in ejection fraction, that is less than 45%, fractional shortening less than 30%, and end diastolic dimension more than 2.7 centimeter per meter square. So coming on the incidence, the European Society of Cardiologists currently classify PPCM as a form of dilated cardiomyopathy of unknown origin. And 1 in 400 live births in United States are there. You see incidence in this graph that is increasing continuously, and even it varies with the age. As the age increases, incidence increases. So less than 0.1% of the pregnancy with comparable good prognosis than the other cardiomyopathy. And there is LV systolic dysfunction. If we talk of the genetic predisposition, it is said that there is a TTN gene with whom it is associated, and it is more in the blacks in comparison to white. As you say here that I have written 13% black women in comparison to 8%, they suffer from this. There is a definite relationship with the prolactin, which plays a very important role in pathogenesis. It is said that cathepsin D that cleaves prolactin into 16 kDa fragment, which causes endothelial apoptosis and capillary dropout and the vasoconstriction, is responsible for this PPCM. If we talk of the placental angiogenic factors and the pathogenesis, during late gestation, it is said that the placenta secretes soluble FMS and tyrosine kinase 1 and anti-angiogenic protein. These are the pathogenesis as we have seen in case of the preeclampsia, eclampsia, or hypertensive disease of the pregnancy. Here there is vascular endothelial growth factor, VEGF, and the placental growth factors, thought to be the major driver of hypertension and the endothelial dysfunction in preeclampsia. They are present here also. So what are the risk factors? They may be probable risk factor, may be proposed risk factor, may be emerging risk factors. So what are the probable risk factors? They may be because of the twin pregnancy. There are increased chances. High parity and high gravidity, there are increased chances. Extremes of reproductive age, there are more chances. Prolonged tocolysis, there are more chances. Preeclampsia, genetics, obesity, I have already explained. Socioeconomic status do affect his African ancestry. It is said that there are more chances. Cocaine abuse that affects malnutrition, hypertension, and smoking. These all increases the incidence of PPCM. Now coming on the etiology, precise mechanism is although poorly defined. There are some proposed etiology. These are the viral myocarditis, especially by the parvovirus, human herpes virus 6, EBV, and CMV. Abnormal immune response that happens because of this, and abnormal hemodynamic response is there. Prolactin, I have already discussed, 16 kDa fragment. Apoptosis and inflammation that happens, and there is responsibility is by the TNF alpha and CRP. Selenium and malnutrition, prolonged tocolysis use, and increased oxidative stress all are responsible. This diagram is a very good diagram that shows this is a normal heart and this is a dilated cardiomyopathy. As you see that all the 4 chambers of the heart are dilated and there are thin wall. So what are the presenting symptoms and what is the presenting sign? I have just drawn in a table form. Presenting symptoms are the paroxysmal nocturnal dyspnea, dyspnea on exertion, orthopnea, chest pain, cough and palpitation, and hemoptysis even. What are the sign? Tachycardia, tachypnea, regular or irregular pulse, persistent neck pain, distension, blood pressure normal or decreased, apex beat, shifted, thirsting in nature, S3 and S4 gallop is present, mitral hollow systolic murmur is there, bilateral basal crepitations are there, and hepatomegaly if RHF is present. So it is very important that you should have a clear cut differential diagnosis in your mind. So with what are the conditions with whom you have to differentiate this particular condition? You have to differentiate with the valvular heart diseases, with the congenital heart disease, with the hypertensive disorders, with the myocarditis, with the pulmonary embolism. You have to differentiate. You have to differentiate with the acute coronary syndrome and HIV. Diagnosis is confirmed after excluding the following diseases. These are the anemia, these are the thyroid diseases, these are the septicemia, these are the idiopathic dilated cardiomyopathy, these are the accelerated hypertension, myocardial infarction, acute pulmonary embolism, severe preeclampsia, pulmonary vasculitis, previous valvular diseases. This is a very good table which shows how to differentiate what are the points on the basis of history, biomarker, ECG, and additional test. You have to differentiate between PPCM, pre-existing valvular disease or congenital heart disease, pregnancy associated with MI, pulmonary embolism, amniotic fluid embolism, and myocarditis. History, you can take that it is most commonly postpartum onset of dyspnea. Here there is earlier onset in the second trimester. Sometimes family history is there. While in the pregnancy associated, there is retrosternal chest pain will be there. Patient will be coming with a complaint of retrosternal chest pain and abdominal discomfort and nausea, while the pulmonary embolism, pleuritic chest pain may be there, and myocarditis is because of the infection. What are the biomarker? In the PPCM, you see that there are elevated natriuretic peptides, as I have shown in this particular case. There are in pre-existing, there are also elevated natriuretic peptides, elevated troponin is there, elevated D-dimer and troponin is there. In all, almost elevated troponin is there. While doing ECG, in PPCM, you find left and or the right ventricular dysfunction, where here there is evidence of pre-existing valvular disease is there. And in pregnancy associated, there is a regional hypokinesis or akinesia. While in the pulmonary embolism, RV dysfunction, elevated RV pressure, and McConnell sign is there. Myocarditis, there is regional or general hypokinesis. Additional test, what are the additional tests? In this case, you can consider MRI. Although if the patient is pregnant, you have to think about MRI. That is not safe, that I'll discuss later on. Here again, you can consider MRI, coronary angiography, CT scan, or MRI. These are the differentiating points. So, as we have just discussed, women with a sign and symptom of heart failure who is in the last month of pregnancy or within the 5 months of the postpartum, what is the flow chart? You see the sign and symptom as I have already discussed. You see about the dyspnea, about the fatigue, about the neck vein distension, about the exercise intolerance, peripheral edema, weight gain, cough, heart palpitation, arrhythmia, and paroxysmal nocturnal dyspnea, hepatomegaly, and weakness. And do the diagnostic test for that. As I have done for that particular patient, of course, CBC, creatinine and urea level, electrolyte level, including magnesium and calcium level of the cardiac enzyme, including troponin, level of B-type natriuretic peptides, liver function, and level of the thyroid stimulating hormone, chest radiography, electrocardiography, transthoracic echocardiography, and cardiac MRI. These are done. Of course, you should include your cardiologist and a physician friend in these all investigations. Coming on the ECG, ECG shows sinus tachycardia, arrhythmias, and example atrial fibrillation, LVH with a strain pattern is visible. You see in the ECG normal or the low voltage, QRS complex with inverted T wave, non-specific ST wave changes. You see in ECG biventricular and biatrial dilatation and conduction defect. The chest X-ray, you see cardiac shadow is enlarged in transverse diameter and see the hyperemic lung fields. And you also notice bilateral pleural effusion. Echocardiography, it shows reduced LV wall motion, dilatation of all the four chamber, particularly the left ventricle. You see the reduced ejection fraction, that is less than 45%. What is the biomarker? As I have just discussed, anti-pro-BNP, CRP, prognosis of the disease के लिए 16K DA prolactin, interferon gamma, asymmetric, dimethyl arginine, cathepsin D, FAS, APO1. So MRI, if we talk, should be avoided in pregnancy. If needed, then use with the considering risk or the benefit ratio. So this PPCM management is a multidisciplinary approach. There is the involvement of an obstetrician, of a cardiologist, of an anesthetist. Management. If we see the management, aims, what are the aims of the treatment? First of all, we have to alleviate the symptoms and slowing the progression of the LV dysfunction and improve the survival of patient. So coming on the treatment, it may be acute treatment or maybe chronic treatment. What are the acute treatment? Oxygen we have to give to the patient. Diuretics, vasodilator, antiarrhythmic, inotropic agent, mechanical ventricular support, anticoagulation, pentoxifylline, IV immunoglobulin, and the bromocriptine. Regarding the chronic treatment, of course, advise your patient about the lifestyle modification, about the diuretic, about the RAS blocker, beta blocker, anticoagulation, cardiac resynchronization therapy, implantable cardioverters, defibrillator cardiac transplantation. So when a patient of this type comes to you, what you do? First of all, you collect your team and do the initial evaluation. Assess the cardiopulmonary distress. See the SBP less than 90 millimeter mercury, heart rate more than 130 per minute or less than 45 per minute. Respiratory rate, see 25 per minute से ज़्यादा होगी. SpO2 less than 90%. Lactate more than 2 millimole per liter. See altered mental status. See the cold skin. Oliguria less than 0.5 ml per kg per minute. Initial evaluation by these all and do the confirmed diagnosis by the ECG, by the blood test, by the natriuretic peptides, by the ECG, by the lung ultrasound. Consider additional tests to exclude the differential diagnosis as we have just discussed in detail. So severe PPCM with the cardiopulmonary distress, or it may be without cardiopulmonary distress. If it is with the cardiopulmonary distress, what will you do? You will optimize the preload, volume versus diuretic, vasodilator if SBP is more than 110 millimeter mercury. Optimize the oxygenation, consider NIV, invasive ventilation, if SpO2 is less than 95%. Add inotrope or the vasopressor. Urgent delivery by the cesarean section should be done in these very cases. Consider bromocriptine 2.5 milligram BD and consider mechanical circulatory support if refractory cardiopulmonary distress is there, or if there is a recovery, transplantation, or maybe weaning. If PPCM without cardiopulmonary distress is there, patient may be in antepartum period or maybe in the postpartum period. If she is in antepartum period, HF therapy, that by the hydrolazine, by the nitrate, and consider delivery in these cases by the vaginal delivery by the PDA. And after that, consider WCD therapy, that is the variable cardioverters, if LVEF is less than or equal to 35%. And postpartum, if lady is in postpartum period, then HF therapy, heart failure therapy, ACE or ARBs, spironolactone, diuretics, consider ivabradine and consider bromocriptine 2.5 milligram BD. And again, it comes that consider variable cardioverters and continue HF therapy. This is a very good flow chart. What are the anticoagulants? Pregnancy itself is a hypercoagulable state with decreased body's natural anticoagulants. So consider anticoagulants in the following patient. These are if LVF is less than 35%, if paroxysmal and persistent AF is present, if documented mural thrombosis is there, if evidence of systemic embolism is there. Warfarin and heparin both are safe during breastfeeding. So what are the assisted devices? These are intra-aortic balloon pump. These are the extracorporeal membrane oxygenation. These are left ventricular assisted device, biventricular assisted device, variable cardioverter, defibrillator, ICD, and CRT. During breastfeeding, what are the things should be avoided and what are the things can be used? Spironolactone, atenolol, and diltiazem and nifedipine should be avoided, while heparin, warfarin, all ACE inhibitors, mainly captopril and enalapril and beta blocker except atenolol, digoxin, these can be used. What are the advices during discharge? This is very important. You have to advise to your patient that daily fluid intake up to 1 to 1.5 liter can be taken. Avoid heavy work and aerobic exercises. Permanent contraception should be advised to these patients. Nutritional supplementation, thiamine and other vitamins and calcitriol and the iron should be given. Pay more attention and consult in case of common cold or RTI. If possible, do light exercises, example walking. Breastfeeding now discouraged for more symptomatic patient. So follow-up of a patient. In this follow-up, echocardiography at rest or low dose dobutamine stress test after the 6 months should be done. There is actually less data about the discontinuation of the drug. If the patient improves, then after 6 months, what you will do? Gradually taper doses of drug up to 12 months. And clinical opinion to continue ACE inhibitor and the beta blocker up to 2 years should be there. So what about the subsequent pregnancy? Usually these type of the patients do come to you and say, madam, what about my subsequent pregnancy? Should I plan or should I not? And what are the incidents? May I recover this disease again? So in the case of peripartum cardiomyopathy, it may present the two types. One is the persistent LV dysfunction, other is the complete recovery. If there is a persistent LV dysfunction, there are higher risk of relapse with subsequent pregnancy and 50% show further deterioration in LV dysfunction, increased morbidity and mortality with SSP, and there may be premature delivery and abortion is more common. In case the patient has complete recovery, there is a better prognosis with SSP compared to persistent LV dysfunction. 20% even in these patients may have a relapse and rate of recovery is higher, morbidity and mortality is lower. So likely to have a normal pregnancy. So you have to always be careful and close monitoring in this particular patient. So what are the take-home message? Now, because of the change in the lifestyle and increasing age of conceptions, the incidence of peripartum cardiomyopathy is increasing. The need of hour is to be vigilant and have multidisciplinary approach. Timely diagnosis and the proper management can recover the patient fast. Advise healthy diet, nutrition, and appropriate exercise to keep your heart fit. So happy heart, no beauty shines brighter than a healthy heart. So thank you very much. Be kind to your heart, be smoke free, manage stress, eat healthy, control your blood pressure, your cholesterol, do proper exercise, and always try create awareness. Thank you very much.
Thank you so much, Kanchanji, for such a nice presentation. You have covered each and everything. With your permission, can I take some questions? We have received some questions.
I think
The
I have
first,
stopped sharing now. Yes,
you have to stop sharing. Yeah.
I have stopped.
Yeah, yeah. Good to see Tazwar. Good to see you, dear. So Dr. Tazwar has joined from the Mumbai. Yeah. The first question is from, we are getting a lot of appreciation. There are some questions. Yeah, one question is from Dr. Rubina Faiz. Dr. Rubina, from where you have joined? Dr. Rubina has sent some questions. Yeah, let me take. Yeah. Her question is, pulmonary embolism risk is up to how many weeks postpartum?
Actually, pulmonary embolism, you have to take the differentiation between the pulmonary embolism and PPCM. PPCM can happen up to 5 months. Pulmonary embolism, you just watch during the time of labor and postpartum, I think 7 days. Dr. Kiran Sinha, madam, if you say.
Actually, I think the pulmonary embolism, cardiomyopathy, these are two different entities.
Different thing. That is
Yeah,
a
pulmonary
differentiation point.
embolism, most of the time it happens during labor.
During labor,
During
and I
labor
think
or post,
not more
just
than
after,
7 days.
yeah, just after delivery. And the cardiomyopathy can happen when
5
the
months.
patient might be suffering from cardiac disease, which is not known even to her or to doctor also. That is why I have said you always investigate the patient. The best thing is to ask the history. History is very important. History is very, very important, and always keep a stethoscope on the heart whenever your patient comes to for ANC checkup. Every visit. अगर उसमें कुछ आपको गड़बड़ लग रही है, always try to send the patient to cardiologist और उनसे proper history बहुत जरूरी. रिस्क फैक्टर जैसा डॉक्टर कंचन ने बताया है कि वो एल्कोहल है, कैफीन है, पुअर लाइफ स्टाइल है, ओबेसिटी है, डिलेड कंसेप्शन है, तो ये सब चीजें आजकल ऐड हो रही हैं. पुअर लाइफ स्टाइल तो है ही है, तो वी हैव टू बी वेरी वेरी कॉन्शियस. And these two have, I don't think they have got any relation, the pulmonary embolism and the cardiomyopathy.
But
Usually, Dr. Rubina, what the studies have shown, the risk of pulmonary embolism is most in the first 3 days. As Kanchanji has also clearly mentioned, is very less after the 7 days. Mostly it is what the studies have shown in the first 3 days, it's more. You can go through the Cochrane study, because when the Kanchanji had told me about this topic, I have read only very little, being an infertility person. So I have read only in some, that also there is one query is there about how much is the risk up to. So in that it is clearly mentioned in the Cochrane studies that more risk is more high up to the first 3 days and maximum up to 7 days. Okay.
And the second question she has asked, I think, at what weeks the ECG and the echo should be done. Yeah. Second question is this. Kanchan?
At what weeks ECG and echo should be done? In normally, actually, first is the clinical sign. Now, because of having more and more risk, we are being afraid. So we are usually doing the baseline ECG and echo. Usually we are advising, because I have told you the different changes. So in the second trimester, usually the gynecologists now they are getting more and more ECG and echoes. Otherwise, if your clinical diagnosis is perfect and patient is looking fine, you can during the expression of these symptoms, you can get an ECG over here.
Kanchan, if you permit, I can say something.
Yes.
And third trimester also. Yes,
Actually, क्या है, जैसा as Dr. Kanchan has said, if you find any clinical sign and symptom, then you can ask for ECG echo at any time. But what I do personally, I have already said that the AICOG guideline, they never say for ECG and echo, it is not in our guideline. But to be on safer side, when you are going, your patient is going to deliver after third trimester, near roundabout term, I always go, especially for
But there is
cesarean,
no
I always go
guideline
for
regarding
ECG.
कि you should do
ECG, I
100%,
think,
but
is
we
must
are
for
doing
every
it.
patient. जब से
Yeah,
कोरोना के
yeah.
बाद ये बहुत सस्ता है, मेरे ख्याल से 100-150 रुपए में हो जाता है ECG. Every government hospital has
ECG
also
हो
got a
जाता है,
ECG
echo
machine.
दोनों
तो
मिला
ECG
के,
तो must है.
हाँ,
मेरा तो
17-18
एनेस्थेटिक
सौ
कराती ही
लग
नहीं है,
जाता
वो कभी कराता ही नहीं ECG. वो तो हमेशा कहता है डॉक्टर साहब इको भी लाइए, क्योंकि बिकॉज एवरीबॉडी वांट टू बी सेफ. लेकिन ECG तो मस्ट. अभी एक हम लोगों ने सेमिनार को कराई थी, फिजिकल मीटिंग, वो आया था ना डॉक्टर श्रीपद अभी पिछली बार. Then I asked this question from that cardiologist also. He said कि madam, ECG should be done at least before in the third trimester. Echo is not very much needed till it is not indicated. Yeah, it was
Ma'am,
his
but
answer.
these days patients are also so much Google savvy. Even yes, of course, they are not mentioned in the guidelines, but I think in third trimester, if the
Right.
patient is having
Ritu,
such
I
a strict,
always go for it
because
because the
there
guideline
are
is not going to save you.
symptoms of the
Yeah.
normal one. They also you have to differentiate. They resemble because of these changes. Nah? So you
True,
can
true,
get it
true.
done. ECG is a very
Yeah,
simple thing you can do in
yeah.
YouTube video
और
also.
मेन चीज है कि स्टेथो हार्ट पे रखना बहुत जरूरी है. इट इज वेरी मच जो नहीं होता है. आई थिंक मोस्ट ऑफ द डॉक्टर्स दे डोंट हैव एनी टाइम टू पुट द स्टेथो ऑन हार्ट. अगर आप हार्ट पे स्टेथो रख दीजिए तो यू विल फाइंड मेनी थिंग्स. आपको तुरंत कुछ ना कुछ डाउट लग जाता है. इफ यू आर इन डाउट, जस्ट सेंड द पेशेंट फॉर द कार्डियक इवैल्यूएशन टू अ कार्डियोलॉजिस्ट.
Correct, correct. Yeah, Tarni madam, you want to add something?
Yeah. Actually, like this Dr. Kiran
Your voice is breaking, ma'am.
nice thing is correct. Actually, we should detail
डॉक्टर
history.
तरीनी फोटो हटा दीजिए तो
We
वॉइस
should take
आएगी आपकी.
detailed history and acid. We should do that. We should take the detailed history and do clinical examination. But I must say that many times in ECG you don't detect any changes. So if the patient is symptomatic like breathlessness is there, or especially after COVID, the immunity has gone down, and if she is anemic and also malnutrition is there, she is not, I mean, good nutrition is not there, then we should go for the echo. And also, if there is she's having a breathlessness and she's prone for the like it seems that she is deteriorating, then we can go for the like lab test troponin, as Dr. Kanchan already has said about it. So that as your clinical examination is very important, but that
And one
Dr.
thing is
Tarini,
very
I just
important.
want to
One
put,
thing is
I
very
just want to,
important.
Kanchan, you will
Wait, wait,
permit.
wait.
level
One thing is very
I,
important.
in the
I
prolonged
just
level,
want to quote a case here. It was not mine case, but my colleague case 2 years back. She went for cesarean section. She was primary. उसके बाद on the third day she started complaining of a headache. So we always used to say it is because of spinal. It might be a spinal headache. So then that lady doctor, I was also there along with her in round. तो हम लोगों ने भाई जैसे कहते हैं ना पानी पियो, ये पियो, वो पियो, लेकिन उसका सिर दर्द, she was not being relieved. Then that doctor and I all took history कि क्या पहले भी कभी सिर दर्द हुआ था. तो कहने लगी हाँ मैडम, मैंने डॉक्टर न्यूरोलॉजिस्ट को दिखाया तो उन्होंने मेरे को हेडेक की दवाई दी थी। अब हम लोगों का माथा घूम गया कि कहीं किसी उसको न्यूरो प्रॉब्लम गई। शी वेंट देयर, उन्होंने कहा कि नहीं डॉक्टर साहब ठीक है। उसके बाद वो लाइगोरिया में चली गई वो। Then because she was a good patient, then that patient was sent to Regency Hospital. There she was diagnosed as cardiomyopathy, and the patient was saved also. So इसीलिए from that day I have decided I will get every patient done the echo and ECG from that day
TN जी
only.
एक चीज और है, इन many cases you find because asymptomatic होता है that appears in the last month of pregnancy. अगर उसने last month से पहले कभी कराया है, 20 weeks पे कराया है या somewhere, तो सब कुछ normal आएगा, ECG भी normal आएगा, even echo भी normal आएगा, even
Yeah.
then she can go into PPCM
Yeah,
in the last
बिल्कुल.
month, है ना, even then she can go.
Not in
Don't
this
be
level,
in
in
the
this case.
confusion कि अभी सब नॉर्मल है तो बाद में इसमें कोई कार्डियक एनोमली नहीं हो सकती. PPCM उन्हीं पेशेंट्स में होता है जिसमें ऑलरेडी दैट इज अ नॉर्मल कंडीशन, बट ड्यूरिंग द लास्ट मंथ और द नेक्स्ट आफ्टर डिलीवरी 5 months में भी प्रॉब्लम हो सकती है.
If there is any trigger,
one thing more, Dr. Tarini and Dr. Kanchan, कि
trigger,
अब मेरे ख्याल से सभी के पास पल्स ऑक्सीमीटर होता है. मैं तो खैर हर पेशेंट का नापती हूँ, ANC में भी और डिलीवरी के बाद भी. तो उसमें अगर आपका पल्स रेट जैसा डॉक्टर कंचन ने बताया 5 to 10%, 10 to 20%, 20 to 30%, उसके बाद 20 to 40% ड्यूरिंग लेबर, उसके बाद नॉर्मल. अगर इससे ज्यादा पल्स रेट आ रही है तो सबसे पहले तो आप एनीमिया रूल आउट करिए कि दैट tachycardia might be because of anemia. Suppose if she is not anemic also, even that the pulse rate is going high, that is the point to think about it. Don't ignore that pulse rate. आपको पता लगे 130 जा रही पल्स रेट, 140 जा रही है, पेशेंट इज नॉट एनीमिक ऑल्सो, 11 है उसका हीमोग्लोबिन, देन दैट पल्स रेट शुड नॉट बी इग्नोर्ड. तो छोटी छोटी चीजें बहुत जरूरी है आपको ध्यान में रखना, क्योंकि मैं तो हमेशा पल्स ऑक्सीमीटर लगा देती हूँ तो उसमें पल्स रेट आ जाती है, SpO2 भी आ जाता है. आई थिंक एवरीबडी हैज गॉट दिस नाउ विद हर टेबल.
yeah, everybody has
पल्स
got
रेट इज वेरी इंपॉर्टेंट, वेरी इंपॉर्टेंट.
saturation also.
एवरी
Both
विजिट
things
यू
we
हैव टू
should do.
टेक इट, एवरी विजिट. क्योंकि देखिए डॉक्टर तरीनी, हम लोगों को ये देखना है कि वी हैव टू डायग्नोज बिफोर द एनी कॉम्प्लिकेशन हैपेंस, एंड आफ्टर दैट वी डोंट नीड टू रिमेम्बर कि उसमें क्या करना है क्या नहीं करना है. नॉलेज होना चाहिए दिमाग में. आफ्टर दैट वी हैव टू
Yeah,
सेंड द पेशेंट टू कार्डियोलॉजी. बट वी आर द फर्स्ट वन टू डायग्नोज एंड रेफर द केसेस टू कार्डियोलॉजिस्ट. तो ये हमको
and,
जानना बहुत जरूरी है. द पल्स रेट शुड नेवर बी इग्नोर्ड. अगर
and
पल्स
many
रेट
times,
ज्यादा है तो सबसे पहले तो आप एनीमिया रूल आउट कर लीजिए. उसके बाद भी अगर जा रही है, पता लगे 20-30% ज्यादा जा रही है, 15-20, तो दैट इज द पॉइंट टू बी कॉशियस.
many times it is silent, but if there is any trigger in future, then it is precipitated and patient go in the cardiac failure.
बिल्कुल बिल्कुल बिल्कुल.
So, Ritu, sir, Dr. Kanchan, the excellent presentation. You have covered everything. जिसको नहीं पढ़ा है उसको भी सब पता लग गया. It was very good. And my greetings to all the like international our guests who have connected and all Indian. And now we are ending probably. Good night.
Thank you so much.
Yeah, thank you.
Thank you,
No, before
Dr.
I wind up, there are two questions. One question is
Yeah.
Sonic Jain. He is joined from Satara. He has written me 3-4 times. Ki, ma'am, please discuss about this. He is asking, madam, what about the role of the this tranexamic acid and mefenamic acid if the patient who has a history of this PPCM and coming to us for the DUB complaint? Is it any studies are there that we can use in that patients, or we can't use the combination of this?
I have not read any study in these study any role of these medicine. Have you?
No,
Have you?
tranexamic acid has got the role in the DUB cases, but not for
DUB.
the cardiomyopathy.
DUB cases, not cardiomyopathy,
His
because
question
I have discussed you the anti clotting agent.
No, ma'am,
There
that
is
is
no
no, he
there
has
is
written.
no contraindication, Dr. Vito, no contraindication in using the patient that is the DUB, symptomatic.
Correct, no? Because he is asking He's already mentioned that, madam, though my question is not related to this, even though I want that there are so many doctors, I want the opinion. Again, he's writing, Dr. Sohim Jain, his name, from the Satara. Huh? He's writing, ma'am, what do you think? Adha question as yes, that what's your opinion to related for the PCOS patients with the heavy menstrual bleeding? He's writing repeatedly. My question is not related to the topic, but I want the opinion of everyone. He's writing, no problem. We all are here. We can discuss. He's writing, can we use still the mefenamic acid or it's totally banned? What the guidelines say?
Hey, it's not banned. You
In
can,
which
you
case?
can use, you can use
Yeah.
symptomatic
Yeah.
trigeminemic B and even mefenamic acid B in PCOS with heavy bleeding. You can always
Yes, we
use.
can use. We can
These are the
use.
symptomatic.
Yeah.
You
Yeah.
can always use.
Yeah. Ma'am, there is, Kanchanji, there is one nice comment we have received. This comment is from doctors joined all the way from Satna. Because some doctors joined via YouTube. A very nice presentation requesting to Ritu madam, please keep on calling such great speakers to have a wonderful discussion.
Thank you so much. Thank you.
So, thank you,
My pleasure.
thank you, everyone. So, yes, there is one question from this Dr. Tajwar. Then we can wind up. There is a last question. Although our program exceeded, program time is only half an hour. It's more than 1 hour now. So, shall we advise ECG to every pregnant lady as a routine? And when to advise?
That I have already discussed.
Hmm.
If we go on the data, actually WHO or ASHRAE, there is no guideline that you should do in each and every patient. But as Dr. Kiran Sinha says, Dr. Tarni madam says that to be on the safer side, you can get it done if you see some symptoms or there is a raised pulse rate or any features, there is a paroxysmal dyspnea, any such features, then you can always advise and refer this type of patient to your cardiologist friend, and you can always get it done, ECG and echo. And once, even if you get it done in the late second trimester or early third trimester, once they come normal, even then even after that you have to be suspicious that once they come normal, you will not be carefree that now the patient will not develop, because in PPCM these patients can, even after previously they are normal, and in the late third stage of the second stage of the labor, and even after the delivery they can develop this symptom.
Dr.
Thank you.
Ritu, since there is no guideline, it is
Yes, ma'am.
individualized. It is individualized depending on your patient's symptoms and signs.
Right. हाँ, वही बोला.
Okay, okay. Thank you, madam.
Thank you so
Dr.
much.
Tajwar is there. Tajwar, if any question, you can ask them directly.
Yeah, ma'am, solved. Thank you so much.
Thank you
Yeah,
so
because
much.
these are the
Thank you.
persons who can solve your obstetric related queries much more better. Yeah, yeah.
Dr.
Thank
Ritu,
you.
one advice as a senior to all my junior doctors, please
Yes, ma'am.
be very careful in taking history, parental history, family history, everything. And the pulse, blood pressure, and the SpO2. These three things are must and is to be written on the paperwork. Because these days actually I was in government job, तो मैंने बहुत audit किए हैं, तो they are very poor in history writing everything. Till they are in PGs, तब तो वो बहुत बढ़िया लिखते हैं, क्योंकि PG में तो इम्तहान देना पड़ता है. उसके बाद जहाँ ये प्रैक्टिस में आए, आई एम सीइंग दैट थिंग, कुछ भी नहीं लिखा होता इनके पेपर पे. और पीजी तक तो बेटा तुम लोग बहुत सेफ हो, कोई प्रॉब्लम नहीं होने जा रही है. व्हेन यू विल बी इन द प्रैक्टिस, देन यू पीपल विल बी पुट इनटू ट्रबल.
You are very
तो
right in your saying,
हाँ
Dr. Kiran
बिल्कुल.
Sinha madam.
और आजकल चूंकि डायबिटिक पेशेंट भी बहुत ज्यादा हो रहे हैं, जीडीएम तो होता है तो कोई बात नहीं, लेकिन प्री डायबिटिक भी बहुत ज्यादा है बिफोर प्रेगनेंसी, तो उसमें भी कार्डियोमायोपैथी के बहुत चांसेस हैं. तो टिल यू वोंट टेक द प्रॉपर हिस्ट्री and the family history and the 75 gram glucose और challenge test वगैरह, तब तक, क्योंकि cardiomyopathy very common in diabetic patient. You never know, the patient may be pre-diabetic even before pregnancy also. She may not be a case of GDM. तो इसलिए बहुत जरूरी होता है इसको देखने के लिए, क्योंकि अभी मैंने एक यंग लड़की को देखा, इसलिए मैंने बताया.
Thank you so
Okay,
much,
okay,
Ritu.
okay. Thank you,
And Ritu,
madam.
link,
Thank
its link will be there, na? Link.
Link I will send you. Once the program will be finished, na, I will send you.
ऋतु
For the-
ऋतु अब तुम अपने हर वो उसको भेज दिया करो लिंक मेरे को, मुझे ऐसे छोटे छोटे चीजें बड़ी अच्छी लगती हैं।
तो मैं तो हर बार I always keep on. Please
अरे आज
keep
इधर
on
हम थोड़े
talking
से
in the
बड़े
English
बिजी
now.
हो गए थे सब दुनिया के झंझटों में। अच्छा
हाँ,
तुम
हाँ।
कब आ रहे हो ये बताओ कानपुर?
Ma'am, wait.
डॉक्टर मीरा मैडम रोज पूछती है तो
अभी
वो
अभी अभी दिस इज लाइव
ऋतु का हुआ कि नहीं वो
शी विल
रजिस्ट्रेशन?
टेल
हमने
शी
कहा
विल
हो
टेल
जाएगा, ऋतु तो आएगी आएगी।
So we are happy to see such a nice interactive participation. Good to see Dr. Rosie has joined all the way from Bhutan. Good to see you, Rosie. So yeah. So with this, we will wind up for today. Thanks to Tarini madam, Kiran Sinha madam, and Kanchan Sharma ji for such an excellent lecture and good interactive discussion has been done today. So friends, please do drop me your messages on which topics you want the session should be conducted. So I will try to finalize on that topics as the time permits. So with this, we will wind up for the today. Thanks once again.
थैंक यू
Thanks to
ऋतु, थैंक यू सो मच।